Good morning, everyone, and welcome to Thyroid Multidisciplinary Seminars. We are very, very fortunate this morning to have a International Thyroid Tumor Board, as we do roughly 8 times a year. This morning's group of discussants is truly fantastic. We are, as they say, live from New York. And live from many other parts of the world here. So Mike, I'm going to hand this over to you if you want to start the intro so that we can get to the cases.
Fantastic. Thank you, Mark. Welcome this morning. It's a delight. We've got some interesting cases to discuss this morning, and I think just some real practical aspects of both thyroid nodule and thyroid cancer. So let's go around we'll have you officially introduce yourself, Dr. Urken.
Yeah, Mark Urken, head and neck surgeon, Mount Sinai, here in New York.
Dr. Robenshtok.
Hi, I'm Eyal Robenshtok. I'm an endocrinologist and thyroid cancer specialist from Israel.
Fantastic. Dr. Pattison.
So David Pattison. I'm dual trained in endocrinology and predominantly nuclear medicine, and I work at the Royal Brisbane and Women's Hospital in Australia.
Fantastic. Dr. Khorsandi.
Azita Khorsandi, radiologist, Mount Sinai.
Dr. Brandwein-Weber.
Margaret Brandwein-Weber. I'm a head and neck pathologist at Mount Sinai West.
Fantastic. Dr. Culliney.
Yeah, hi, Bruce Culliney, a medical oncologist, Mount Sinai, mainly downtown.
Fantastic. Thanks very much. And we'll go ahead and take those slides down. Let Fernanda bring her slides up. Our presenter this morning is Dr. Fernanda Vaisman, who we all know very well. And in the disclosures that I have to disclose, both Fernanda and Dr. Robenshtok were former fellows of mine. So if I treat them either too nice or too rough, that probably explains why. Or if the three of us gang up on Bruce and Dr. Urken, you'll understand the behind the scenes pattern. All right, Dr. Vaisman, let me have you introduce yourself and then we'll get started on the cases.
Good morning, everyone. Thanks for having me here in this fantastic board. I'm Fernanda Vaisman from the International Cancer Institute in Rio de Janeiro. So let's get started. So these are my conflicts of interest. I am a principal investigator of several clinical trials now, and we're going to talk about drugs in some places here. So these are my disclosures. So first case, this is a recent case of ours. It's a female, 50 years old, found a 3-centimeter nodule during a routine almost 10 years ago with an FNA that was benign. And she came to us to see if she needs to do anything else.
Okay, let's go back for me just a second.
All righty.
And it begins. Margie, how good's a benign FNA? I mean, is it right 100% of the time or 95% of the time? What number should I?
You're asking the wrong person for that because I'm not a cytologist, but my answer is usually something like,
Pretty good.
No, my answer is, but I can't give you numbers. It's a benign biopsy is by itself is probably, unlike, let's say 50% or so likely to be correct. It's about a coin toss. Now, then you put that in the context of the TIRADs and stuff, you may come up with a better idea, but, it has its limitations.
Yeah, so Eyal, expand on that just a little bit because Margie's right. I just asked for the FNA alone, but we interpret that in context of the history and the nodules. So talk a little bit about that.
Right. So one of the problems that we have specification for ultrasounds and we have specifications for FNA results, and we have to look at them together. Because if it's a low risk nodule with benign FNA, then 97-98% of the times it will be benign. But if we have a large hypoechoic nodule, one FNA which is benign may not be enough to tell us it's really benign.
And David, in Australia, part of the challenges we have is how radiologists describe these nodules. Some people use ATA, some people use TIRADs. Any feel for or is there any uniform approach of how they're read down there, David?
Look, I think like elsewhere in the world, there is a bit of variation. And it does actually depend on different centers. It depends on the degree of speciality. If it is part of a a larger thyroid center, I mean, our center uses TIRADS, but there is variation. Yeah.
Mark, how long do I have to follow these guys? I mean, Fernanda's nearly 10 years into following this patient. They had a benign nodule. What's your sort of, when do you do the ultrasound follow-up? Do these people ever get out of ultrasound follow-up?
Yeah, I think that that's really a wonderful question that doesn't have an absolute answer. And so my practice normally is to do follow-up ultrasounds at about a year to establish stability. And then it's really a conversation with the patient to get a better sense from them. So if I establish a very stable nodule that hasn't changed architecturally, probably after 2 more follow-ups, I will tell them to come back as needed, but I'm not sure that there's absolute data to support that.
And Fernanda, how does it work? I mean, you have people come from all over Brazil, which is a huge country, travel to Rio to see you. I mean, do they have to come back to see you? Can primary care doctors do this? How do you do one that looks benign on the ultrasound and you got a benign FNA? How do you do that?
Yeah, and I think one of the things that this illustrates is how TIRADS or the ATA classification changed and facilitate our day-to-day life. At this point, this is 2015, we didn't have that. So, it was a lot of different reports that we got, and it was even more difficult to interpret the Bethesda in this context. But usually these large nodules, we follow in this referral center for 1 or 2 years, and then they come back to primary care, and if there's something different, they can come back.
And Eyal, how do you do it in Israel?
So we usually follow these patients, especially the larger nodules. It's a small country, so we tell a patient to go to their local endocrinologist, and they tell you they live 30 minutes away. So our clinics are packed with these patients. So when we have larger nodules, we follow them more. With the smaller nodules, come back in 5 years, and then they forget about it, and they come back eventually. But we follow them for too long, probably.
I think so too. And I think Mark's right. We don't know what that data is, but that's something we need to look at. I mean, we're using a lot of money and effort and time for cases that often don't change. Now, this is being presented at Tumor Board, so it's going to have to change. So what's going on, Dr. Vaisman? Next slide.
So she had a new ultrasound in another institution that showed enlargement, but a long time after the first one. She spent like a few years not following this, and she got another FNA, and this is when she came to us with a different result, a little bit larger, about 8 years on the road.
So Margie, I know you're not a cytologist, but you're closer to the cytology than I am. So do I just get to pick which one? 7 years ago, it was Bethesda II. I like that one better. Now it's Bethesda IV.
No. Right. No, you don't get to pick. So, Bethesda 5 means, let's go. Let's schedule this, the surgery in this circumstance.
So Bethesda 5 would, but this one's being read as Bethesda 4. So the repeat is being called Bethesda 4.
Right. So, okay. So what's your question? Which one do you get to pick?
No, how often? Any idea how often they change? I mean, I tend not to do repeat biopsies unless something's growing. So I can't actually say. Oh, how about doing in this one? How about doing molecular if you don't know what to do? Eyal?
So it really depends how the nodule looks like. Because it was 3 centimeters, now 4.2. If it's a round nodule, it's almost double in size. Though in centimeters, it's small, but because it's round, it is a significant growth. If it's a hypoechoic nodule, which is growing, I would send them to the patient for surgery, because I'm thinking every time I see such a patient, if I do molecular markers and then it grows further, what would I do? I'd send the patient for surgery. So if it grows and it's hypoechoic, probably for surgery. If it's isoechoic, looks benign, I would consider molecular markers.
Because if it looked benignish to you, then if the molecular markers came back negative, you would be willing to cautiously watch some more. That's the logic?
Right, to follow. Yeah.
Yep. Mark, I assume by now you already have this nodule taken out of this patient's neck while we're deciding what to do?
Yeah, this one's, well, I think it comes back to this discussion with the patients, but a growing nodule with a change certainly in New York, that raises the level of concern. And by this point, obviously, this patient's reemerged from an 8-year hiatus. I think there's probably a level of anxiety here. And if this were me or a family member, this alone would probably pull the trigger.
What if the repeat biopsy was Bethesda II, Mark?
So if it was Bethesda II, again, it would be that discussion. I would be probably a little bit more inclined to monitor as long as the patient had no symptoms, as long as they were not terribly anxious about the change in size.
And Eyal, if it came back Bethesda II for you, I mean, I guess you would be willing to watch if it was molecular negative. Would you still be watching if it's Bethesda II?
If it's Bethesda II, again, in the ultrasound is not suspicious, yeah, you would follow. There was a big study from Italy, multi-center study. They looked at a lot, about 1,000 thyroid nodules, and just a few had cancer, and growth was not predictive of cancer. So, yeah, if it's benign, I would follow it.
So Fernanda, go ahead, Mark.
Yeah. So you made the jump that if it came back Bethesda II, and molecular was negative. If this came back Bethesda II, Mike, would you or Eyal, would you get molecular testing in light of the growth?
Yeah, for me, no. No, I think cytology trumps it. Although that's a good question, because if it did come back BRAF or something weird, we wouldn't watch. But to me, it's sort of how much growth was it? And I think 3-dimensional is the way Eyal's thinking about this, right? We just got 1 dimension here. And we also have this gut feeling, is this the growth that we've seen in benign nodules? So, I don't know what that is, but when it feels faster than that, or if the ultrasound showed suspicious features, right, that would trump a Bethesda II. But if it looked like a benign nodule, Bethesda II, although I would tell her she's 50 years old, do you want to have surgery when you're 50 or surgery when you're 60? Because in all likelihood, this is going to continue to grow. But in the Italian study, not all of them did. Some of them shrunk over time. So interesting. So Fernanda, she was your patient. What was the discussion and how did you guys sort of walk through this?
So, as you said, Brazil is a huge country. The first ultrasound was a long time ago. We don't know, how good was the ultrasonographists that did this. We did worried about the growth, but we're not, we're not confident that this was the actual growth, that it grew that much. She was asymptomatic. She didn't have any. She didn't have any symptoms, and this is as Eyal said, it's not a slightly growth. It's a big growth over time. She would feel it, and she didn't. So we were kind of, did it really grew or not? But anyway, we repeated the ultrasound here. It looked benign, and we went on molecular testing as you guys suggested. Can I go?
Yep.
Can I go
please.
further? Yeah. Okay.
Yep.
So this is the summary here. She had no abnormal lymph nodes. I didn't say that, but we did have a neck ultrasound to check that. And this is one of the molecular testings that we have here. Is a Brazilian one. It's been validated, and as you can see here, it tested also some mutations here, and it's based on microRNA, and it came back negative, which downgraded the risk of malignancy from a Bethesda IV to 4%, like close to a Bethesda II.
Yeah, Azita, before we move on, when I send you old CT scans and old MRI, you guys seem to do a good job comparing those. Somebody else's ultrasound in pictures, Fernanda was saying that was one of the issues here. Was it really changed? Thoughts about sort of comparing those versus, more traditional cross-sectional imaging?
So I used to do ultrasound. The volume got so much, I stopped doing it. I always compare with the ultrasound. You're supposed to use the ultrasound for diagnosis. Ultrasound trumps CT, except you know, we've talked about this before, the margins, extrathyroidal extension, which you can most of the time see it better on CT if there's tracheal invasion, if there's vocal cord paralysis, some of the central compartment nodes, but I always compare with the ultrasound. And then I think CT and MR are complementary most of the time.
Yeah, and I think for the audience, what you heard Fernanda sort of talk through was the things Eyal was asking about. Does it look benign? Do we really know it changed this much over time? It clearly changed some because she can feel it now, right? So we know it's changed some, but nothing that rose any big wells. Mark, are you comfortable following this one, or are we going to do lobectomy anyway? We got negative molecular testing. We've got a benign appearing ultrasound. She's asymptomatic. Going to leave it entirely up to you.
Yeah, so I think what we don't know is really what the rate of change is, you've alluded to. And so I don't think you lose anything in this situation by repeating an ultrasound, but I'd probably do it on a shorter time interval. I'd probably go have this patient come back in 6 months and repeat it, unless the patient, for all those reasons, wants to have this removed.
Eyal, if we're convinced this is benign, I mean, if we were sitting in Europe, people would be talking about radiofrequency ablation for decreasing the size. You have a feel for what, we're not doing that right now, but a feel for what that role might be now or in the near future?
Yeah, so we started doing radiofrequency ablation, and turns out it's really good for nodules up to 2-3 centimeters. The really large one, they are tough. It takes a lot of time for them to shrink, and it's painful because it's a lot of ablation to do. So it's best with nodules that don't bother the patient. With the larger ones, it can be done. It can be successful. It's not an easy procedure for the patient, especially after treatment. And we never do it for if we have any suspicion of cancer. And just a note, in this case, when we see a large nodule like this, the thing that we're worried about, that we don't want to miss ever, is metastatic follicular thyroid carcinoma. So we have these nodules and they grow when we have molecular markers. And it's always the question, if this is the 1 out of the 1,000 that you're going to miss distant metastasis. Today that we do less surgery and we use molecular markers. So if it looks worrisome, we feel it's worrisome, growth, the way it looks and things like that, we take it out. But it takes experience, and it's hard to do it black and white, as we see in the panel here.
Yeah, that's always the concern. If this was one of those follicular lesions, the driver of metastasis is the vascular invasion, right? That we're not going to be able to see on the ultrasound. Margie, when I'm following some of these, not just the Bethesda IIs, but some of the small RAS, some of the follicular lesions, I generally have this impression that like the widespread vascular invasion, which is what I'd worry about, I really see in the bigger ones rather than the smaller ones. Is that true, or am I just making that up?
Yeah, I can't say that that's true. I can't say that that's true. I would say that extensive vascular invasion is not common, you know, but in my experience, I can't say that it's one or the other. I do want to make a comment about the ultrasound measurement. I was very struck when one of the ultrasonographers had mentioned, maybe it was in this venue, maybe it was in Thyroid Tumor Board, that the ultrasonographers look at our reports and our measurements to calibrate their measurements. After I heard that, I'm always comparing our measurements with their measurements. Sometimes it's spot on, sometimes it's not, you know? So again, that just casts more doubt on this change of in the ultrasound.
Yeah, I think anecdotally, when I compare the ultrasound versus the path report, I think the path reports are generally a little bit smaller. I mean, I always assume that's because you guys were dehydrating them and putting them in paraffin and that sort of stuff.
No, not at all. Not at all. Because, you know, first of all, when it's measured, it's being measured fresh.
Oh, on the first, when you're getting it on the table? Oh, yeah.
but without blood flow, without
Sorry?
blood pressure, without blood flow. So it's a bit smaller. This is what I think about.
Yeah.
Great, that's a great idea, Eyal.
Yeah. And then sometimes you get completely fooled that the size in the ultrasound just doesn't match the report and it's infiltrative, and you guys tell us why. Okay, next slide. Let's make a decision here. We're going to go around the horn, and we'll let Fernanda tell us the final answer. David, if this was your mom, what would you be thinking here?
Look, I'd be voting surveillance, actually.
Surveillance, good. Eyal?
I think in this case, I would send, if depending how it looks like. If it doesn't look suspicious, then surveillance. If it looks hypoechoic, I wouldn't do molecular testing and would set the patient for surgery beforehand.
So you're doing pre-test probability that's really a cancer despite the stuff. Mark?
Yeah, I think I would circle back to what I mentioned before. It would be a shorter interval follow-up. It would not be a year. I would repeat an ultrasound in 6 months, and really have a lengthy conversation with the patient.
I think that's a good idea. 4 or 5 centimeters, do one in 6 months, because the volume really can change, as Eyal was saying. If it's 1 centimeter, maybe not. Fernanda, what did you really do with the patient?
So she came exactly for evaluation for radiofrequency ablation because we're starting clinic here, and we thought she was not a good candidate for that, and we just observate her and perform another ultrasound in 6 months. It didn't change, so we did another ultrasound in 6 months, and this is where we are now because she didn't want surgery. She didn't want to have the risk to take thyroid hormone pills because her thyroid worked perfectly. So we've been following her closely as suggested here by the panel.
I'm going to say a word or two about where you are using RFA, Fernanda, because I know your group's been has been looking into this. Are there certain nodules that you really think would be good for RFA?
Yeah, that's exactly what we all said. Usually the best ones to do RFA are the ones that you'll be perfectly comfortable following. So that's the thing that we struggle in clinic now. So they're smaller, they usually don't bother the patient. So the ones that we are pretty convinced we have a good indication are the ones with cosmetic problems. So the ones that are anterior, that the patient complains, it feels like a lump in the neck. And some patients, they want to see that shrinkage. So we have a better experience, as they all reported, with a little bit larger nodules, benign, but with FNA, Bethesda II, 2 FNAs, not like this one that we confirm the benign with molecular testing. So this is something that's not very well studied yet. So we don't do that in Bethesda 3 or 4, even with a negative molecular testing.
Yeah. Okay, somebody's going to say something?
Yeah, last question here.
Yeah.
So we get a 6-month follow-up. Eyal, Fernanda, Mike, what amount of growth would change your opinion? Obviously, it's going to be different than for a micropapillary that you're following and on follow-up surveillance. But what would change your impression here if 6 months from now? How much growth would you need to see?
Eyal?
Nothing happens in 6 months usually. Even if we have some growth, it's not within 6 months. If within 6 months we have significant growth, let's say 1 centimeter, is going to be really unusual. But usually it's a couple of millimeters, if any, and it's going to take more time for us to determine if there's growth or not. And we need to look on volume to assess volume and not just the maximal diameter.
Yeah, I think that's really the key. You have to do 3-dimensional volumes on these. I mean, the ones of us that look at our own images or do your own ultrasounds, you're already having that in your head. But if it's a report, you're going to get fooled. It's going to a few millimeters in multiple dimensions and something that's 5 centimeters is a pretty big volume change. So I think on one like that, Mark, I'm not looking because I'm worried I'm missing a cancer anymore. I'm just looking to say, is surgery inevitable? And if it is, let's do it sooner rather than later. would be my approach to that. Okay. All right, Fernanda, let's talk about pregnancy or thinking about pregnancy. Next slide. In the setting of a suspicious thyroid nodule, we'll talk about some pregnancy issues. Okay, let's do the next case, Fernanda.
So this is case 2, a 35-year-old girl with, again, a routine ultrasound with 2.5 centimeter thyroid 5 nodule at this point, no abnormal lymph nodes. She wants to get pregnant soon, have an FNA, Bethesda 5, suggestive of papillary thyroid cancer.
All right, Eyal, with that history just starting there, how does focusing primarily on this desire to get pregnant, recognize she's 35, we don't have years and years to figure this out. How does that already begin to think about how you're evaluating the nodules, what you're thinking about in that 30,000 foot view, Eyal?
Just for now, if we can do a lobectomy, and it seems like we can do a lobectomy, let's have a lobectomy as soon as possible, and she can get pregnant. It's problematic when we diagnose this type of lesion during pregnancy. But if she wants to get pregnant, we can do it as fast as possible, just to see the TSH 3-4 weeks after surgery. And it looks like if it's with one focus within the thyroid, we shouldn't need any radioiodine, then it's easy, such a case.
Perfect. So Eyal lives in a perfect world. In New York, it's not so perfect. She calls you the next day and she tells you she's pregnant, Mark. How does that factor into what you're doing here now? I mean, we don't even know it's thyroid cancer yet, right? We just got an ultrasound. You've got a thyroid 5 that's likely, and she's now a month and a half pregnant.
Yeah, so she, in these situations, we monitor patients through pregnancy. Normally, I'll get an ultrasound somewhere towards the beginning or the middle of the second trimester, just to make sure we're not missing anything significant. But this patient gets followed up. There's no need to do any further workup at this point because it's not going to change anything. So we'll ride this patient out through pregnancy and then a repeat ultrasound in a month out from delivery.
Okay. So if I go back to Fernanda's case, she's not really pregnant. But she wants to be, probably in the near future here. And she gets a Bethesda 5 suspicious for papillary thyroid cancer. David, what are you thinking here?
I mean, I'm thinking kind of like what Eyal said before, that it's something that if she wants to get pregnant soon, she's 35 years old, it is probably better to move ahead with, planning for surgery, potentially, and
get this down. All right, and Fernanda, let's keep going. Where did we go?
So we studied her neck a little bit further. She had no abnormal lymph nodes. No, she did go. She was very anxious, and she did want to go for a preoperative, what we don't do routinely here, for a preoperative molecular testing to know her prognosis. And then she got a BRAF positive mutation, and this one that was a papillary thyroid cancer. And she wanted to know which kind of surgery we would do to her, because she wants to get pregnant and she wants to keep her thyroid, but she read online that this is a very aggressive mutation she has.
We've all seen that. Eyal, any role for routine molecular testing in these Bethesda 5s? In this case, it helped her because it's, this is papillary thyroid cancer, right? Not suspicious for thyroid cancer.
So we see a BRAF and TERT combination, which is a sign of a more aggressive disease, which is rare. But BRAF mutation is very common. And as long as we have a solitary nodule, which is within the thyroid, it does not change the risk of long-term outcome. So it's worrisome for everyone around us. The patient, they go online, they see how bad BRAF mutation is, but in most cases, it's not helpful. But unfortunately, in the last Bethesda guidelines, they added molecular markers also to Bethesda 5. We don't use it, and I think it causes over treatment and stress, and I don't see much value with this assessment in Bethesda V patients.
Margie, in the past, all the BRAF mutation stuff we got was from next generation or PCR. Now I see BRAF V600E and even some RAS immunostains.
Yeah, but I know
talk about those. Yeah.
Sure, I know they do that at Memorial. We don't do that here. On the other hand, we don't need to because our BRAF is so rapid. But you know, I know that Ronnie, you know, sets a lot of store by them in terms of their specificity. You know, so he will, you know, he will use that to make a diagnosis of NIFTY-P histologically versus not NIFTY-P, et cetera, et cetera.
Yeah. Mark, do you routinely get molecular testing in Bethesda V? And then secondarily, if you do, does it change what you do?
So again, it really comes down to the patients. I do, if for a nodule 2.5 centimeters that is in a size range that I would feel comfortable just monitoring for a bit, it would change, it would have an impact. But I don't think it's essential. Once I have it and it's BRAF V600E, it doesn't change my surgery other than it just sort of heightens my inclination to look a little bit more at those central compartment lymph nodes on the same side.
So Mark, I've heard some surgeons, I think the ones that don't routinely do central neck dissections, say that having BRAF changes what they do. The ones that routinely do it, it doesn't change. Does that make any sense, or help me understand that a little?
Well, we know that BRAF V600E is associated with an increased risk of nodal metastases. So, you know, I think that the whole issue of staging central compartment nodal dissection is something that's quite controversial. We have a journal club coming up, and I think in Europe it's really become a part of how they approach these cancers or these situations. I think the question then becomes, what do you do? What do you do with that information if you come back with a single lymph node that is positive on frozen section? Does that drive the necessity to take out the other side? And there's really not a good answer to that. Certainly if you find multiple lymph nodes, that's going to influence how you deal with the intraoperative decision making. So I think it's a heightened part of awareness. I think it does drive me to take out those ipsilateral nodes much more readily, and those get sent for frozen section.
And David, how about down under? Molecular testing, Bethesda V, changing what you guys recommend at Tumor Board?
We wouldn't necessarily routinely be doing it that much, to be honest. Yeah.
Yeah. So Fernanda, how about you guys? Are you using it in this Bethesda V? Is it changing surgical decision making in your Tumor Board?
So usually we don't use it. So she just came in with this, you know, when you work in a referral center, you get like second opinion and third opinion of everything. So she came with this done outside, and we were struggling with this information. We didn't want to have it at this point. That I'm being honest here, because I think maybe it can lead to over-treatment more than benefiting her. But, you know, we had the same discussion that you guys are pointing out. And, you know, should we look at central compartment or not? How, you know, aggressive will we be if we find a lot of little lymph nodes? You know, would we do a completion? Would we do a more extensive neck dissection? She wants to get pregnant. What if she comes back with hypopara? What are we going to do? Are we going to harm her more than do any good knowing this information? Because, you know, you have to remember that she has an ultrasound that didn't show any lymph nodes anywhere. So, I mean, that's what we're not doing it routinely, but sometimes we get this information. I don't really know how to use this at this point. So what we did is exactly what.
Hold on a second. Go back.
Sorry?
Hold on. Yeah, wait right there. So I think what you're hearing in the discussion here is we're trying to make this balance between Should we be more aggressive? But if you're more aggressive in the central neck, we're going to get more hypopara unless you just stay on one side, but that's going to lead toward total. More recurrent radial nerve damage. I mean, it'd be a disaster to send this lady through. I mean, we're doing all this to let her get pregnant. Send her through pregnant, hypopara, or with a nerve that is not working, right? But on the other hand, David, these BRAF tumors don't concentrate radioactive iodine as well as we want to, right? It's not zero. I mean, how do you sort of think about RAI avidity and your ability to clean up if Mark left some little microscopic stuff behind?
Yeah, I mean, it certainly is. It's one of those key characteristics that BRAF V600E mutants, they are less likely to accumulate radioactive iodine. So I guess that means that, the preference is obviously making sure that the surgery is as good as possible, that first time round, because we are less likely to concentrate radioactive iodine for sure. And then, if it does end up being one of those bad players again, and there is either, persistent disease or distant metastatic disease, typically they're less likely to have good uptake and respond. So,
Eyal, last comment before Fernanda tells us what happens here. Any last comments, Eyal, before we move on?
We would go for lobectomy, and during surgery, the surgeon, like Mark said, will evaluate in every patient.
Yeah, so just careful. Yeah, that's my concern. I mean, sometimes I wish I didn't even know the BRAF V600 because whether we admit that we're going to do something more, there's that tendency to do a little bit more. And we have to remember that most people in the world getting thyroid surgeries are not being done by our expert surgeons that have low complications, right? So when we talk about being more aggressive, I do worry in these folks. On the other hand, if you have a BRAF V600E that 2.5 centimeters, you're not going to be surprised if you find some microscopic lymph nodes in that prophylactic central neck, right? That's the natural history of this. So go ahead, Fernanda, tell us what happened.
So she got a lobectomy with the central neck dissection ipsilateral. And not surprisingly, we found like a very small lymph node in the four that they had taken out. And she's doing great, no complications. But, have we did any good for her doing this central neck dissection? As you said, well, we're not sure.
Finish this one up for me, Mark. She comes back to see you 10 days after surgery. This is a path report. What do you tell her about the path report? Completion, radioactive iodine, keep following. So what's your talk with her at this point?
Yeah, this is so the proviso is that there's nothing in the opposite lobe, and that's kind of the baseline here. In the absence of anything on ultrasound in the contralateral lobe, I will minimize the impact of this 2 millimeter lymph node and tell this patient that she will be followed the way we do with with all patients in this situation, with follow-up testing by ultrasound primarily, because we know that thyroid globulin is not going to be a great help here. So she gets followed, and she's aware that should something emerge in the future, she may need a completion thyroidectomy.
David, if she comes to you for an opinion, everybody always worries about these little lymph nodes, and by God, it's BRAF. How do you frame sort of the follow-up there, David?
So I think, I agree with what Mark said. My key thought is that, what would we do if we didn't have that BRAF testing? We know that BRAF is quite common, in PTC. So I would phrase that, like, I wouldn't let that influence the decision-making too much. And I'd also say, again, it's a very, very small, element of disease within that lymph node. And, it wouldn't change management in that perspective, and that this surgery could have been done without actually sampling the the central neck. And again, we wouldn't know about that small focus. So I talk about that often. The risk of recurrence is there, but it's not particularly high.
Yeah. Eyal, let me change it just a little bit. When they did the surgery, they found 4 lymph nodes, but all 4 had papillary thyroid cancer, and the biggest one was like 8 millimeters, 9 millimeters. But does that change? Do you still keep following Mark's watching program, or how do you? Is there a place you draw the line there?
Okay, so it is a spectrum. It's common sense that a 2 millimeter lymph node and 3 centimeter lymph nodes are different. And to frame this question, about a decade ago, the ATA Surgical Task Force, Greg Randolph and friends, they did a framework. They looked at the literature and they gave numbers. So we know that if we have less than 5 lymph nodes, 1, 2, 3 millimeters in size, then the risk of recurrence is low. It's below 5%. When we have more than 5 and larger than 1 centimeter, then it's around 20, 30%, and it's a spectrum. If she has 4 lymph nodes up to 8 millimeters, we would do a completion. But if she plans pregnancy and I'm not going to give her radioiodine, I may follow up just with ultrasound and defer the decision. And she needs to understand that the risk for recurrence is higher than if we hadn't had these small lymph nodes.
Great context. Before we leave this case, there was a couple of questions in the chat from the benign nodule. This one will go to you, Fernanda, from Dr. Pinar Smith here in New York. What pre-procedure criteria do you need on a benign nodule before you do the FNA? You know, they've traditionally been 2 Bethesda II biopsies, and the question was, is a Bethesda II plus a Bethesda IV with molecular negative, would that qualify?
Mm-hmm. So now in the routine basis, we are using just to treat benign nodules, and you have to have 2 Bethesda II. No doubt about it, no question on the cytopathologist if it's a Bethesda II, and then you can do it. We don't limit by size, so we are doing great larger nodules, but as said before, with a mild a worse response than with small nodules, but you can get a larger nodule with more than 1 session. It just gets more expensive. We don't have that experience of very painful procedures, but people are it's better. They get more. They want to have that rather than taking their lobe out. This is what we have here, and you have to have a very nice, either ultrasound or CT with contrast to study neck lymph nodes before doing that.
Great. Mark, there was a question for you on that same benign nodule that we started with. You said repeat the ultrasound in 6 months. The question is, would you repeat the biopsy as well and then do like 2 out of 3, or you're just using change in size?
I wouldn't unless there was a change in ultrasound features. That I don't see a value there.
Yeah, because the question on that one is just rate of change. That's the piece of information we didn't have in that one, right? Is this changing slowly or rapidly? Okay, cool. All right, let's do a different topic. Let's switch to medullary. Next one up, Fernanda.
Alrighty. So this is case number 3. This is a male, 50 years old with a neck mass. This is not a routine ultrasound. He felt that in 2020. It's like in the middle of a pandemic. He had initial workup with this. It was a 2 centimeter nodule in the right lobe, highly suspicious with ipsilateral abnormal lymph nodes. He had, again, a Bethesda V, suggestive of medullary thyroid cancer. He was operated during COVID pandemic, MTC 2.3 by 1.5 centimeters, 16 positive lymph nodes. The greatest one had 1.5 centimeter with extranodal extension. So he got a thorough thyroidectomy, central and lateral neck dissection. Shortly post-operative evaluation still showed some metastatic lymph nodes. So he got operated again with a few other lymph nodes taken out.
Okay, pause there for me. Hey, Margie, let me come back to you. Another cytology question. Medullary pops up sometimes in Bethesda III, sometimes in Bethesda V. Sometimes I get, this is definitely cancer, but it's not papillary. That's the report that I get. You get to look at all the pathology. Help me understand why this cytologies kind of get read that way.
Well, medullary thyroid carcinoma is the melanoma of the thyroid. because it can have so many different appearances. And it can also, and of course, so many different presentations. I remember Mark having a case where it was read as negative, right? The FNA was negative, but there was like, you know, correct me if I'm wrong with this one, but there was like, you know, multiple nodules of medullary thyroid carcinoma all throughout the thyroid. But did I remember that one correctly, Mark?
I believe so, yeah.
Yeah. So, so I think the short answer is it's the melanoma of the thyroid.
Gotcha. Yeah, so they pop up all over. Azita, in one that's coming in like this, 2 centimeters, we know it's medullary, there's abnormal lymph nodes. If you had to pick your best study, because we're gonna have to guide Mark with regard to his lymph node dissection. We're not really thinking about tracheal invasion, that sort of stuff, but extent of lymph node dissection, and you got to pick CT, MRI. How do you sort of think about that?
I like CT, but again, you know, I would map out the lymph nodes and just say they're indeterminate, because unless you do a dotatate study, I can't tell by looking at the lymph node whether they're positive or negative. I've seen 2 millimeter lymph nodes that are positive. I've seen 10 millimeter lymph nodes that are negative. So I can't go by pattern of enhancement. I can't say it's cystic, calcified, or any of the features we use for PTC. So
Just map them out.
stuff, yeah.
David, I hear about these F-DOPAs, I hear about dotatate. Take a couple minutes and help us understand how nuclear medicine can help us image medullary and kind of neuroendocrine tumor. That seems to have changed a lot in the last 5 years.
Sure. Yeah, no, it has. So the main traces that, well, there's really 3 PET traces that we'd use in medullary thyroid cancer, you know, that are potentially available. We don't use all 3 of them. But there's dotatate, which is imaging somatostatin receptor distribution. It's particularly useful in, you know, gastroenteropancreatic neuroendocrine tumors, but it's also of value in medullary thyroid cancer. And in that setting, I mean, it's good, but it's not generally the best. F-DOPA is a DOPA analog, and that just happens to be particularly well concentrated in patients with, you know, particularly those patients with slowly growing, more slowly growing medullary thyroid cancer. And it really is, you know, exceptionally accurate. And studies comparing that with dotatate, it is superior. But the other factor is relative to the calcitonin doubling time. In those patients that are growing more rapidly, they will tend to be more avid on FDG. And in fact, FDG in those patients, particularly with a doubling time of 6 months or less, or even, you know, less than a year, FDG tends to be favored. But with those with a slower doubling time, we tend to use F-DOPA at our institution.
Hey, Bruce, let me bring you in here. We haven't forgot about you. We finally got up to something gets into oncology land here. In addition to imaging, there's been a lot of change in sort of how we treat the bad medullary cancers. We'll talk about somatic testing in just a minute, but in the setting of distant metastasis and the medullary cancers, assume it's a RET somatic mutation. How are you thinking about these metastatic medullary patients now, Bruce, as compared to 10 or 15 years ago?
Well, I mean, I think if you have the, you know, somatic RET mutation, then I think, you know, you would want to give, you know, more directed therapy with like sulfatinib, you know, as opposed to, you know, earlier vandetanib or cabozantinib. So the response rates are much greater, duration response is greater, toxicity profiles are greater, are better. So I think in this case, clearly there's concern based on the amount of lymph node involvement and also rapidity of further disease in a very short period of time. So, yeah, I think this is a patient who's likely going to be, you know, a candidate for systemic therapy in the future, but likely if it's a RET positive, that's going to be very important to make a determination.
Mark, let me actually ask you about the initial surgery, then I'll ask Eyal about sort of the role of somatic testing. This patient, medullary cancer, presenting with lymph node metastasis. Talk a little bit about sort of your upfront imaging that you usually do, Mark, and the surgery that you would plan.
Yeah, so the surgery is already mapped out by what the information that we know here. And I think just the question that Azita brought up And actually, I want to circle back to David because it raises an interesting question. What we're really looking for in a preoperative cross-sectional imaging, and for me, CT really is the way for me to look at the mediastinum and look at the retropharynx. Oftentimes we get something in the retropharynx that we're just not sure about. So David, is there a role for preoperative nuclear testing to help decide whether anything that looks maybe a little bit funny, whether we need to go after that?
Yeah, so I think the main role is, as you say, well, one is to identify distant metastatic disease, but, and that, depending on the extent of that, may influence, it can be occult, particularly, if it's below the diaphragm or in bone. But obviously also from the point of view of local staging, I mean, we find it is quite helpful to know with confidence, particularly to resolve indeterminate findings, like you're saying. It is very helpful because you can characterize that as has been alluded to earlier, and particularly in the more challenging areas that would influence your surgical approach, if it is extending into the superior mediastinum. But again, the other question is access and cost, of course.
Yeah, because what Mark you're alerting to is when you have lots of lymph nodes in the neck from the medullary, there's often retropharyngeal, there's often upper mediastinal, and we want to get a good clearance of all of that, maybe not with the first surgery, but that first few months of taking care of this, right? You're trying to, but you also don't want to be operating on something that turns out not to be medullary if you're way up or way low.
Right.
And it's particularly good because you can confidently characterize nodes that are sort of 3 or 4 millimeters if they're very avid on F-DOPA in particular.
And Eyal, what are you thinking here?
About what?
in terms of
in this type of patients, when they come, this patient had 2 surgeries. Usually the discussion that we have is, okay, this is where we start. We still don't know where we're going because the doubling time of calcitonin is the best marker of good disease or bad disease. We've seen patients who start with calcitonin of 3 and eventually have 10,000 and have distant metastasis. And we've seen patients with calcitonin of 1,000, which are stable for years and years. So we always have this discussion. This is where we start. We're going to have some data in 6 months. We're going to be smarter in 2 years. And then we're going to see what type of disease you really have. Yeah. And I try to be optimistic, but this is what we need to wait for.
Right. And if you know their medullary beforehand, knowing what the pre-op calcitonin gives you a good idea. Are they a good producer, a bad producer? So let's move to the next slide, Fernanda, and give Dr. Robenshtok a little bit of the follow-up that he wants.
Right. So we got a germline mutation that was negative. So this is not familial medullary thyroid cancer. Post-op calcitonin came back greater than 5,000. He got a liver MRI with liver metastasis.
Okay, Dr. Robenshtok, there's your early response to therapy. What are you thinking now?
Okay, so this patient has a liver metastasis. Again, we need to see the size, whether they are growing or not. We always prefer to treat locally. If it's in the bones, to radiate it. If it's in the neck, to do surgery. If it's in the liver, to locally treat it before we think about systemic therapies. Because we have a small amount, just few medications that we have for systemic therapies, and they don't work forever. So in this type of case, we see the size. Do we need to treat it now? Do we follow it? And we always try to use local treatments first.
Fernanda, obviously, anybody with medullary, we do RET germline testing. I honestly don't care if they're 2 or they're 70 years old. So we test them all. When do you do the somatic testing of the tumor, looking for those? Maybe the tumor has a RET mutation just inside the tumor that Bruce could treat. So what are the times in the medullary cancer you think about not only germline testing, or what point in the future do you do the somatic testing?
I think we have the thing here is if we look at this patient and already stage him in our heads, we would say that he's a very high risk patient for having distal metastasis and be candidate in the future for systemic therapy. So when I see this locally aggressive disease, I think all of them need a somatic testing. Just even if they won't need in the near future, maybe, you know, along the road, they will need, and we will want this information, maybe to save him for some more morbid surgery in the future, and, you know, try to choose the best treatment for him. So we usually test patients with aggressive disease, with very small medullary thyroid cancer, no lymph nodes. I don't see now a role for somatic testing, because I don't think this will be the candidate for systemic therapy in the future.
Bruce, we'll often see in medullary that they, at least early on, appear to have kind of isolated liver mets, you know, 1 or 2 big liver mets. You don't see anything else going on. But how do you kind of decide whether you do something locally, as Eyal was saying, ablation or embolization or surgery, versus the systemic therapy, even if you knew they had a somatic rep mutation? Bruce?
Well, as sort of was alluded to before, I think it's if you have just isolated metastasis, then that would be the way to go, because as you know, we don't have a lot of treatments. And once you start systemic therapy, even the rep mutation directed therapy, I mean, treatment continues until it's no longer working or no longer tolerated. So you're sort of lost your treatment. So if you have just local disease, whether it's liver, bone, whatever, then you certainly want to take advantage of local treatment, and then follow closely for additional disease, whether it's significant progression of disease, or is also what was alluded to before, as far as aggressive nature of calcitonin, doubling time is short, then that could influence systemic therapy. So yeah, so I think local therapy always first, because systemic therapy, once it starts, it doesn't stop. Pretty much.
Mark, in the last couple minutes, just thinking about the other new things in medullary, this whole idea of neoadjuvant therapy. So if this was like a really bad tumor in the neck that was either unresectable or borderline resectable, if you resected it, you would have to take out trachea and that sort of stuff. Do you have a feel for using, like this was a RET positive tumor, selpercatinib or pralsetinib, to try to shrink to make surgery better? Any feel for how that's working right now?
Yeah, so it's obviously an extremely hot topic, and as in most things in medicine and surgery, we tend to jump on the bandwagon early, and then the pendulum swings back to a more reasoned approach here. So I think it really, every instance, every situation is different, and I think the question that always comes up, if it's borderline resectable, are we missing a window if this disease progresses during neoadjuvant? And we're not going to know those results sometimes for a period of time, and that may be a critical window. So I think there are indications for sure. If it's unresectable, then by all means, then it makes sense.
You don't want to take something that's resectable and God forbid they fail and then it becomes unresectable, right? That's the challenge. We're starting to do some of the neoadjuvant. MD Anderson's got some pretty impressive data, but I think it really is patient selection, getting that right person. Some of them have been pretty impressive. Other ones, we took something that was borderline resectable and made it smaller borderline resectable, but probably didn't hurt them. So we were able to follow along. So we're right up at the hour. That's the finish of our hour. I would like to thank the entire panel. Dr. Vaisman, thank you for some great cases. I think just some practical cases about nodule and managing thyroid cancer, that pre-pregnancy issue, and allowed us to talk about some of the newer aspects of medullary cancer in the patients you were taking care of. So I wish everybody a wonderful rest of the week, and thank you again for participating. Thanks, team. Thanks, Fernanda.
Thanks, everybody.
Bye.
Thank you.
Bye. Bye.